with that, I want to introduce Dr. Carl Christensen, who has been practicing in our community for how many years, Dr. Christensen?
15, I think.
15 years. Okay. For those of you who don't know Dr. C's story, he is in long-term sobriety, 20 plus years, and works with one of the inpatient rehab clinics in Washtenaw County, knows quite a bit about the subject that he's going to be discussing today, which again is the truth about teens and marijuana, straight talk about the drug's effects on the developing brain. And I wanted everyone to know there are medicinal benefits to marijuana that we're not going to discuss today. I personally think that there's a place for it given the right need, but we're going to today talk about teenagers, young adults. I also know that for pregnant women, weed isn't a good thing. And with that, for more on this subject, Dr. Christensen, I'm going to turn it over to you to discuss your PowerPoint and this important subject.
Okay, thanks for the invitation to speak. My name's Carl Christensen, and I'm an addiction doc practicing in Ann Arbor. I have a associate clinical professor appointment at Wayne State's Medical School, and I'm on the advisory board for Northwest Wayne FAN. Don't have any financial relationships to disclose. And I want to thank these people for providing some of the information for tonight's slides, especially Dr. Juni, who is here at Ann Arbor, Dr. Yanga, who's the medical director at Brighton Recovery Center. And we have to start off by defining addiction because that's going to be the underpinning for this talk. And a lot of people think that addiction is just physical, meaning that when you stop a drug or a substance, you go into withdrawal and you get over the withdrawal and then everything's over. Or you can say that you are a weak-willed person, which is a very popular theory, or you're a bad person, which is popular, or it's an actual mental illness. And we'll look at each of these briefly. The first one is known as tolerance and withdrawal. Those are the parts of physical dependence. And tolerance means you need to get more to get the same effect. So if I'm taking Xanax to deal with the stress of my job, eventually my brain will get used to it and I'll need to take more and more Xanax, and then I'll run out of Xanax, and the withdrawal will be the opposite effect of what Xanax was designed for, which with that drug can be dangerous because it can lead to a seizure. Now this sounds like addiction, but it's not. Tolerance and withdrawal will happen to anybody who uses a medication like a benzo or an opioid or a stimulant for more than 1 or 2 weeks. It's normal. You can say that addicts and alcoholics are weak-willed, and these are 4 gentlemen that I picked out of history who are alleged to have a problem with alcohol and drugs. The 2 on your left were alleged to be amphetamine addicts. The 2 on your right were alleged to be alcoholics. And you can say what you want about any of these folks, but no one has accused any of them of having a lack of willpower. You can say that those with addiction are immoral, bad people. Everyone recognizes the guy on the right. That's Freud. The guy on the left is named William Halsted, and he was considered to be one of the greatest teachers of surgery that ever lived. And these 2 gentlemen became addicted to cocaine, and no one could cure them. No one could fix them. And they are considered to be folks who had their medical careers ruined by cocaine. You can actually see a video on them if you go on YouTube and put their names in. So we're left with talking about this as a mental illness with an actual brain disorder. And to look at this, this is the picture of a rat brain. The frontal cortex, which is the thinking part, is on your right. The hindbrain is on your left. And the villain here is called the nucleus accumbens, and that responds to the drug called dopamine. And dopamine is the drug that causes wanting, and it also is involved in liking and pleasure. And this is inside the basal ganglia. The gas tank for the nucleus accumbens that provides all this dopamine is right behind it. It's called the ventral tegmental area. And if you look at all these drugs here, the drugs of abuse, they either act directly or indirectly on the nucleus accumbens to cause reward and make you keep using a drug. There's a small part of the brain up here called the amygdala that is involved with emotional memory. So if you have a very strong emotional experience, the amygdala will store it, and reactivation of a memory like this can lead to a relapse. Then you have your prefrontal cortex, which is what you are. That's your executive thinking center. And we'll show you how parts of the nucleus accumbens affect the prefrontal cortex and vice versa. But the prefrontal cortex is supposed to put the brakes on. It's supposed to inhibit your pleasure center. And addiction is a cycle. It doesn't just happen once. And there are supposed to be 3 parts of a cycle: binging, withdrawal or hangover, and then craving. The binging is involved with the nucleus accumbens, like we just talked about. The withdrawal part involves the amygdala, that emotional part. And then craving or preoccupation involves the prefrontal cortex. And the binging doesn't have to be alcohol or drugs or cannabis. It can be something like food. And the 2 drugs that are involved in your nucleus accumbens are dopamine, which makes you want it, and your own opioids, your own heroin that makes you like it. And this experience here is what we call pleasure. And then the good part wears off and you go into withdrawal. And the drugs here involved are all drugs that are unpleasant: norepinephrine, corticotropin releasing factor, and dynorphins. Dynorphins are designed to make you feel bad. They make you feel dysphoric. So that's, for example, part of having a hangover the day after. But a hangover goes away, and what you're left with next is the craving part. And that's your prefrontal cortex, which is supposed to tell you not to do it again. But if there's damage to your prefrontal cortex, or if you're actively involved in addiction, it doesn't work. And there's 2 drugs involved here. There's glutamate, which tells you to do it, and GABA, which tries to stop you from doing it. And there's also something called positive and negative reinforcement. Positive reinforcement means I drink or I use drugs to get high and I enjoy it. It rewards me. But after a while, as my addiction wears on, I spend all my time in withdrawal. So I start using just to get out of withdrawal. I don't enjoy it anymore, but I don't want to be in withdrawal. That's negative reinforcement. And that's where addiction winds up. You spend all your time trying to get away from the withdrawal, and you have forgotten about the good old days where you were enjoying your drug or alcohol or cannabis use. Another way to look at this is what's called allostasis. And let's look at the top picture here. This is a normal person. Let's say you go out tonight after this talk and go to a bar and you get drunk, or you eat, or you use cannabis or whatever. You wake up the next morning and you don't feel good. You got a hangover, but it wears off by noon and then you're back to normal. That's homeostasis. You get back to where you were. But if you keep using over and over again, your highs get lower and lower until finally you spend all your time down here in withdrawal. And that's what someone will tell you if they're recovering from an addiction, is that at the end, all they were doing was using to feel normal. They weren't even getting high anymore. And that's allostasis. Also, if you've probably heard that dopamine is the pleasure drug, and that's not really entirely correct. There's 2 different drugs involved. There's dopamine, which makes you want something, and then there's your own opioids, in this case called enkephalins, that make you like something. There's also a natural THC, anandamide, that strengthens that association, and this gives us the feeling of conscious pleasure. And there are a couple spots in your brain that are called hedonic hotspots that are responsible for giving you this conscious pleasure, and the nucleus accumbens is one of them. If you have a chance, I think this article is available online without any charge. It's from Scientific American. It's older, but it's written by Dr. Berridge from Ann Arbor, who is actually a world authority on the way the brain works in terms of liking and wanting. And that gives a very good discussion of how it actually looks. So let's talk about, let's talk about cannabinoids. This sounds kind of circular, but cannabinoids are drugs that work on the cannabinoid receptors in your brain and your body. There's two kinds. There's CB1, that is the one that's in your brain, and that causes euphoria and partially pain control. And then there's CB2, which is in your blood cells, and that's responsible for controlling inflammation. And that's where CBD or cannabidiol may come in. The ones we're concerned about tonight are mostly phytocannabinoids. Phyto means plants. So this is the drugs that come from cannabis. There are hundreds of them actually, but there are two we're concerned about, THC and CBD. They look similar, but they have dramatically different effects. You can get these in capsules, spray, and oil. That can be CBD. Cannabis, which is marijuana, can be smoked, eaten, or vaped. We'll talk about which one works better later. There are two versions that are licensed by the FDA. One is Marinol, one is Nabilone, and these are used primarily for chemotherapy patients, those who have wasting diseases like AIDS, and they're used to stimulate appetite and control nausea. There's a drug that's available in Europe, but not here in the US. It is a 1-to-1 mix of THC and CBD. And the reason for that is that CBD is a drug that helps reverse the effects of THC, making you high. And I'm going to show how that is being kind of bred out of cannabis plants. And again, this is not available in the US. CBD is what people buy to control pain. It can be put in food. It can be put on as a lotion. When you buy this, you need to know that it probably has some THC in it. And if you have a job that does drug testing, you have a very good chance of testing positive for THC. This drug, Epidiolex, is pure CBD. It's used for childhood seizures. The problem is it costs something like $4,000 to $7,000 a month. So it's not something that's an option for most people, but it's for childhood refractory seizures. You can vape it, you can smoke a joint, you can eat gummies. Gummies are dangerous for two reasons. One is that kids will find them and think that they want to eat the candy, and a child can have a lethal overdose of cannabis gummies. The other is that you may take these for pain relief and they don't kick in for a couple hours, and you're going to get impatient and you're going to take more and more. And then when they finally kick in, you're going to be toxic and you can very easily wind up in the emergency department. And here's the CBD oil we just mentioned. So is marijuana legal? And you all know the answer is yes. It started off with medical marijuana, I believe, in 2009. And that was not a prescription, but a certificate from a doctor that you had a condition that would be helped by medical marijuana. And this was done pretty much by a consensus, and some of the conditions were extremely strange. There's decriminalization. Those of you old enough to remember the old Ann Arbor days when Ann Arbor made possession of marijuana a $5 ticket. But now there is also legalization, and that means commercialization. And they estimate that in Michigan alone, cannabis is turning into a $2 billion industry. So big business is here. Remember, though, that Michigan is considered to be what we call an at-will state, which means that if your employer says you cannot test positive for THC, you lose your job as a result of this. And I have seen nurses, pharmacists, respiratory therapists, doctors who have gotten in huge trouble by being tested at work, usually a hospital, testing positive and being taken off work. So one thing is, what gives you the best high? And this is something that has been studied. And what they did was they compared smoking marijuana to vaping cannabis, and they looked at the euphoria, and they also looked at the damage to your cognitive effects or cognitive system. And they found that vaping, which is green, was better at making you high and also better at impairing your cognitive function. So vaping essentially makes you higher and dumber at the same time. And when someone says they are vaping to avoid eating something or smoking something, you have to realize that they are getting more effect on their cognitive system, their brain function, than they would be if they were smoking it. There's also something called EVALI, which came about 2 or 3 years ago, electronic cigarette vaping associated lung injury. And there were people who had their lungs horribly damaged by this. And it turned out that they were vaping vitamin E. They were putting vitamin E in THC oils in order to bulk it up. People were inhaling this and severely damaging their lungs. This was about 90% of the cases. And this has been taken out of most of these, but it's something that can occur because these vaping oils are not controlled. What is happening to cannabis in terms of strength? Is it getting stronger, or is that just like an urban legend? This is looking at between 1960 and 2011, the strength of THC and CBD in cannabis. Here's the THC concentration going up to about 11% or so. And here's the CBD concentration that is a flat line. Remember, I told you that CBD will lessen the euphoria you have from THC. So the people that are the big business do not want this, okay? Even if it helps in terms of inflammation and pain, it's not a good thing for them. Now, you might say, well, so what? Who cares if THC is getting stronger? And if you had an alcohol problem and came to me, I would not tell you to switch from strong Jack Daniels, which is 40% alcohol, down to light beer, which is about 3 or 4% alcohol. So how strong a drug is doesn't really mean anything. But there's something else going on with marijuana. Let me show you. This is a graph on the bottom, the black line, looking at the number of cannabis users in the US between 1986 and 2010. It's gone up from 10 to 15 or 17 million. This is the potency of THC that we just looked at. And right next to it are the number of admissions for drug treatment for cannabis use disorder in the US. These two lines are almost identical. And no one really knows why, but the stronger cannabis is getting, the more trouble people are getting into. And if you are in the audience, if you're anywhere near around my age, from the 60s and 70s, the cannabis that was around then, there is simply no way to compare it to what we have now. And then you can get into oils and things called dabbing, where the potency or the concentration can be as high as 80%. And that is nowhere near, and we can't even compare that to what is out there in the past. There's something else that is known as synthetic THC, which is called K2 or spice. It is versions that do not show up on a drug test. They are up to 800 times stronger than regular THC. They can cause psychosis, permanent brain damage. There have been deaths. And luckily or not, the DEA has passed a law saying that anything that works on your THC receptor is the same as THC. So this is no longer legal, but it's still being purchased on the black market. And you've heard some horror stories about K2 victims. There was one that happened about 2 years ago where a Florida man assaulted someone, horribly damaged someone's face, and he was allegedly using K2 rather than something like LSD. So the next thing is, does cannabis cause addiction? And let's just go over the definition of addiction. There's 4 different parts to addiction. You have to have impaired control, which means you can't stop, you take more of it than you wanted to, you spend all your time using it. Social impairment, which means you give up your obligations at work, you give up your normal recreation activities, you give up your family responsibilities, you use it when it's risky, and you have tolerance and withdrawal. And these are the criteria that I use with the patient anytime I'm trying to figure out whether or not they have what we call a use disorder or an addiction. And overall, the chance of being a cannabis user and becoming addicted overall is about 9%. However, the younger you get, the more likely this is to happen. And adolescents who are regular users have twice the chance of becoming addicted. If they are regular users and they are daily users, it can be as high as 25 to 50% will develop a cannabis use disorder or cannabis addiction. And just to compare it to the other drugs, this is always surprising. Nicotine leads the way in terms of causing addiction. Then there's heroin, cocaine, alcohol, and cannabis. Cannabis is roughly about half that of alcohol or cocaine in terms of a user becoming addicted. So is your daughter or son using cannabis? And there's some things to look at. This research actually came from U of M. This is a very famous study called Monitoring the Future. And the top blue line going from 75 to 2013 is what percent of 12th grade students used cannabis during the past year. The red line is how dangerous they thought cannabis use was. And you can see that these two are opposites. As the perceived risk goes down, use goes up, and vice versa. And unfortunately, perceived risk is going down and use is going back up. So we're heading back up currently in terms of 8th, 10th, and 12th graders using marijuana. And here's the numbers. 50% of 12th graders have tried, 35% have used it in the past year, and 20% have used it in the past month. And there are lower numbers up here for 8th graders, but again, these are significant numbers. These are higher numbers than 12th graders using alcohol or tobacco. So this is a more common drug use than either alcohol or tobacco by high school students. And again, a significant number of 12th graders are using it on a regular basis. How about car accidents? This is something that became very big when Colorado first made marijuana legal, and people were saying, well, it did or it didn't increase the accidents. And it's very hard to be certain that THC was involved in an accident, because if you get arrested at an accident scene, by the time you get to the hospital, your THC level may be normal. So it's hard to tell. But this is the biggest article written on this. And here's what they found. In states that legalized marijuana, there was no increase in fatalities that involved THC. However, when you decriminalized it and made it recreational, there was a significant increase in the number of drivers involved in fatal accidents who tested positive for THC. And this was felt to be due to availability. I couldn't resist showing this. This is a picture taken on the very first day that marijuana was legal in Michigan. This was a young man who was celebrating and smoking marijuana, driving down the road, and he drove right into a state trooper. So this is something that you really want to avoid if you can. How about mixing this with alcohol? People frequently mix alcohol and marijuana together. And here's some more area of concern. You always hear jokes about someone being high on marijuana and driving down the road at 15 miles an hour. You can learn to compensate for that. You can tell yourself, I got to drive 55, and you can do it. However, when you drink, that part of your brain is wiped out. So you can't tell yourself what to do when you use both, and the two together are much more dangerous than either one alone. Another thing is, you probably saw this billboard in 2017 when we had the election that legalized marijuana for recreational use. And the claim was that states that legalized marijuana had fewer opioid-related deaths, and that cannabis was a good thing. Let's look at that. This is where this comes from. This is a well-known researcher named Dr. Bachhuber, and he looked at states that had no medical marijuana laws. He looked at states, He looked at states that had medical marijuana laws, and there is a difference. There were more deaths from opioid overdose in states who did not have medical marijuana laws. And that's where this claim came from. But another researcher did a bigger study, and this is hard to interpret, but if you look at the black line and the red line, and down here is the year the study was done, if the black line is below the red line, it's safer to be in a medical marijuana state. If the black line is above the red line, it's more dangerous to be in a medical marijuana state in terms of death from opioids. And this is where Dr. Bachhuber did his study, and then he stopped. And for some reason, when the study was followed out, somewhere around 2014, it became more dangerous to live in a medical marijuana state. You were more likely to die from an opioid overdose. So when someone makes a claim that marijuana prevents opioid overdose deaths, it is not backed up by evidence. Another concern is, does marijuana cause brain damage to adults or to adolescents? And what they found was, in doing a twin study, meaning you take identical twins, one who uses cannabis, one who doesn't, and then you follow them. In this twin study, it was done in New Zealand in 2012, teenagers who used frequently had an average IQ loss of 6 to 8 points. 8 points is big. It's a big drop in IQ. When those teenagers stopped using, they did not recover their IQ points. However, adults who began using marijuana heavily did not lose any IQ points at all. So the concern here is that when cannabis use begins in adolescence, that there is significant decrease in IQ over a period of time, and even worse, it doesn't recover. Now, this study has been contested. People are still fighting about it, but I think it behooves everyone to realize that this research showed a decrease in IQ points. This is what's called a SPECT scan, which this is not an actual picture. It's looking at how your brain is functioning. And this is a normal functioning brain. And this is an 18-year-old daily cannabis user. These are not real holes, but what this means is that this part of your brain is not active. And you can see that there's a big difference between the healthy control and the daily THC user. Another thing is, when we first got our medical marijuana laws, did that increase cannabis use in teenagers? And there was a lot of controversy about this. And I want to show you this paper from 2015. This is written by Dr. Haseen, and she is a heavy hitter. She was one of the authors of a DSM-5 manual, which is what everybody uses to make a diagnosis. And here's what they found. These are the different states that have medical marijuana laws. Here is this dotted line down the middle. If your state is on the left, then adolescent cannabis use went down once you passed a medical marijuana law. If your line is on the right, your state had more adolescent cannabis use. And overall in the US, there was no increase in cannabis use in adolescents when they passed medical marijuana laws, except, look at this one here on the bottom, Michigan. It says 0.25. And when I saw that, I thought, well, 0.25 is no big deal. But this is a logarithmic scale. And what this means is that in Michigan, there was a 77% increase in adolescent cannabis use when they passed the medical marijuana laws. And obviously, that's something to be concerned about. So who gets a medical marijuana card? Just to warn you, this is a a friend of mine, Dr. Bill Maroney, he has presented at Washtenaw Fan. He is vehemently anti-medical marijuana, so I rewarded him by photoshopping his picture on a medical marijuana card. But this is a survey of medical marijuana users in a clinic in Michigan. 96% were using for life. 73% were under 50. 68% had a history of opioid abuse. 35% were cocaine users. This is not the picture of a chronic pain patient, okay? So when people say that medical marijuana clinics or marijuana clinics are visited by those who are only in chronic pain, is simply not true. In some states, having opioid dependence is criteria for getting a medical marijuana card, currently not in Michigan. And just to glaze over these next two slides, what this shows is that if you compare anxiety, depression, addiction in people who never use marijuana, people who use it rarely, and people who use it a lot, either using it rarely or using it a lot gives you an increase in the chance of having a mood disorder, an anxiety disorder, or an addiction disorder. And this slide lists all these psychiatric diagnoses from left to right. Cannabis users are the green bars, controls are the red bars, and for every single psych diagnosis, there is a higher proportion who are using cannabis who have that diagnosis. Now, for all these studies I just showed you, there's one important warning. We're talking about associations. We have not proved causation. So one thing I always like to make as a point is people eat ice cream in the summer. People go swimming in the summer. When people swim, sometimes they drown. So ice cream consumption is related to drowning, but it doesn't mean that ice cream is causing any of the drowning. So you have to be careful because these are what we call observational studies, not experimental. In almost all of these cases, we didn't have any control over who was doing what. All right, let's move over to talking about treatment. And we'll talk first about medications that are used to treat cannabis use disorder. And the first one, which is the most important one for this talk, is what's called Mucomyst or N-acetylcysteine. This is something that is available very easily. It's used for cystic fibrosis or COPD, and it was used for teenage cannabis users who didn't want to stop, which is a perfect experimental group. And what they found was there was a big decrease when they used this medication, but the teenagers still craved it, and when they tried it on adults, it didn't work. But this is something that may have potential for teenagers who are using cannabis. Or you can use THC to stop THC addiction, and there are two different versions. The problem is that people liked THC more, and they didn't stop using, so that was a bust. There is a drug that we already mentioned that's available in Europe. It's a combination of THC and CBD. It was tried in Europe. It did not last for long. People started relapsing, and it may cause impairment. There is a drug called gabapentin, which a lot of people have heard of. It did help with withdrawal, but there were some patients who had suicidal thoughts. And then there is CBD. I've already mentioned that that might oppose the effects of THC, and these are studies that are currently ongoing. There's another drug called naltrexone, which you have heard of probably as Vivitrol, but it's also had side effects, including cardiovascular effects. Let's look at the behavioral treatments for cannabis use disorder. Let's look at each one of these. Motivational enhancement, which is where you don't tell somebody what to do. You try and get them to talk about it and to formulate by themselves that they should change their behaviors. There's mutual help, which essentially is either 12-step programs or smart recovery. There's cognitive behavioral therapy. There's something called contingency management, and there are programs that are based on getting the family involved. So for motivational enhancement therapy, this is where I listen to you rather than tell you what to do. And if I make a suggestion and you push back, we don't start arguing, I just kind of back off. And this has been very effective with alcohol and tobacco. It helps somewhat for adolescents who are using drugs, but it appears to help primarily by getting them in some other kind of treatment. There are 12-step programs. We have Marijuana Anonymous, and you can go to marijuanaanonymous.org. They have meetings here in southeastern Michigan. There's what's called CBT, or cognitive behavioral therapy. And the idea is that if I have a drug problem, I have a false belief that makes me feel bad that leads me to using. And CBT helps to identify what those false beliefs are. It also does what they call relapse prevention, where I learn to avoid situations where I might use. There are volunteer groups, and the most important one, the most available one, is called Smart Recovery, and that uses CBT principles, and it's available online and also in person. There's contingency management, which has a bad rep. The idea is that you get paid for having an abstinent or a negative drug screen. And it is something that works very well with stimulants. It was first used with methamphetamine, where almost nothing else works. And the way to think of it is that if you had an adolescent child who you wanted to encourage abstinence, your driving privileges were given to you for a negative drug screen, and your driving privileges would be removed for a positive drug screen. And then we have the family-based programs. There's 3 different types here. There's what's called CRAFT, which is community reinforcement approach. And this is based on the family, either parents or spouses or significant others, who learn how to use positive reinforcement on their loved one. There's Al-Anon, which is a 12-step program based first on Alcoholics Anonymous. For cannabis, it's called Mar-Anon. And then you have the interventions you used to see on TV, and it can either involve the family or it can be a confrontational approach. And that was first developed by someone named Vernon Johnson. And here's what they found. They did a study where they didn't randomize you. They let you pick which one you did. They gave you 12 hours of teaching, and then they came back a year later to see how it worked. The CRAFT had 64% success in getting someone into abstinence. The intervention had 30, and Al-Anon came in dead last at 13%. And it worked better if the significant other was a spouse, was a parent rather than a spouse. So to wind up, this is a list of places you can turn to. If you go to Psychology Today online, for every county in the country, you're going to see a list of therapists that offer different services. And the services that I just mentioned, they will list whether or not they offer those. University of Michigan is called UMATS, and here's the phone number. For Ascension, it's Brighton Center for Recovery. For the Henry Ford system, it is Maple Grove. And for the Trinity system that I work for, it's known as Greenbrook Recovery. And this is one of our rescue dogs that was one of our therapy dogs when we had our private practice open a few years ago. And thanks everyone for listening.